from the ACT, from the Northern Territory, from Queensland and Tasmania. So first up, I'd like to introduce Sarah from Hepatitis ACT.
Hello, everyone. I'm Sarah from Hepatitis ACT, the land of the Ngunnawal people. The timer will be on soon. So this project was the first time that Hepatitis ACT was offering hepatitis C hepatitis testing in a community-based setting, and existing strong demand among our client cohort for community-based testing and significant interest from right from project commencement. And the main strategies that we used were conversations with clients about the project, including and especially highlighting the nurse practitioner model care, ease of access, incentivized participation, and the availability of educational workshops and peer support. We also highlighted the fact that there will be a lot of peer outreach activities in priority settings and relational engagement amongst peer networks of service users. The main thing that we wanted to highlight was that the clients understood the nurse practitioner-led model of care was safe, supportive, and person-centered. This was critical in breaking down any hesitation about engaging in hepatitis C testing and treatment due to previous experiences of behavioral or conditional stigma. An early indicator of success for the model was the number of people living with diagnosed chronic hepatitis C who were referred by their peers to the project and commenced treatment. So the way that this project was done was we partnered with a nurse practitioner who had already had a lot of experience working with people in the alcohol and other drug sector, and especially with BBVs. We also partnered with the Canberra Alliance for Harm Minimization and Advocacy, who provided us with peer workers and peer support. And the way it went was we would provide people, first of all, with a lot of information and education around how the nurse practitioner-led model of care would work. They would then come and get tested with us. The nurse practitioner was amazing at talking to people about vein care and also letting people make choices on how their veins would be accessed. Once they got treated, once they got tested, we tested about 94 people over a 9-month period. Of those 94 people, 24 people actually tested positive for Hep C RNA. Of those 24 people, 10 people commenced treatment through our nurse practitioner. 2 people were referred to specialists. We also did a lot of workforce development, obviously working around COVID and, sorry, the timer thing. But okay, so we also tried to do a lot of workforce development around it. And we have to thank ECA Australia's team because they were so supportive in adapting to COVID, and we kept changing the model, and they were like, okay, that's fine. We can support you in the service delivery, and that's fine if you have to adapt. And it's okay if we change these things. But they also helped us build capacity within the organization, which we are carrying on even now. And really what this meant was, because the pilot was such a huge success, we were able to turn this pilot project into a program that was then funded by ACT Health. And it's now a bigger, more exhaustive program, which means that we now have more services and more partnerships in place with now a GP practice. Some of the things, some of the key learnings, it's not showing that. Okay.
Sorry. Yeah, problem. Well, I have to do something up here. Can we, instead of doing sign language, let's just try and talk.
Oh.
They're giving me the eye. So
they're like, well, do something. Yay. Okay. All right. So what we would do differently next time would be, if point of care testing was available, which it is now available, what we are doing now differently is we do have point of care testing available. We have operators who are trained both with CAMA and hepatitis ACT to provide testing anytime. Our nurse practitioner clinic was once a week, which was great, but we also lost a lot of testing opportunities because of that, which we now have remedied because we now have point of care testing. We also tended to rely too heavily on text message reminders for people to, go get your pill, go get your scripts, come back and talk to us. So maybe a better communication strategy was needed, which is what we are doing now. We are a lot more proactive with our communication with our service users and participants. Communication was so key. I think we could have done a much better job with communicating about not just what the project was, but also the philosophy behind it. A lot of people thought that we were trying to become a primary healthcare provider, which was not the case. And I feel like if we had communicated this better, it would have been better received within this sector. And planning, lots of planning. Yes, planning. Okay, my time's up. Should have planned this better.
Thank you, Sarah. Any questions for Sarah? Yes, Joe.
Hello. I'm just wondering, with the nurse practitioner model, was it MBS billing or were they salary paid? Or how did you fund
MBS
this?
billing.
Okay,
Yes.
cool.
Yeah. So they're so they were an independent nurse practitioner who had their own clinic and they invoiced us for their services, which was really nominal. They were just doing community services for us, really. We were very lucky to have the nurse practitioner for how long we had them, but yeah.
Excellent. So I guess what would you recommend in future? Like what kind of model, like funding model would you recommend in future for something like a nurse practitioner clinic?
Whatever works for them, really.
Okay, cool.
I
Awesome.
can't tell people what to do, but whatever works for that organization and the nurse practitioner would be the best model of care.
Cool.
Yeah.
Excellent. Thank you.
Peter?
Sorry, I came in a bit late rudely. Were there incentives on offer for people to get tested?
Yeah, so the nurse practitioner-led model of care actually coincided really well with the Reach, Teach, Treat pilot that we ran. And so there were incentives. People got cash incentives for getting tested. And then they got cash incentive for commencing treatment. And then they received a cash incentive for getting their SVR12s. So yes, it was really, really successful. And with the new program, the next program iteration of it, we've actually increased the incentives. So now people do get incentives for their second script as well. Yeah. And my time's up. Thank you, everyone.
Thank you, Sarah. I apologize for that technical issue. Please go and look at the poster over there. It's the first one over there in the corner. So thank you. Our next duo is Ange and Sal. So thank you very much, Nurse Peer Partnership from NT.
Hi guys, I got my chicken scratch notes here. So yeah, we were doing the EC project up in Darwin. It was the Nurse Peer Partnership and we did lots of partnering. So we also partnered with the NT AIDS and Hepatitis Council, Menzies School of Health Research and NT Health. With the aim really was to provide people at risk of or living with hepatitis C to access Hep C services outside of the hospital setting. Our approach was really person-centered and we were really fortunate, I think, that we had the model of care, the resources, the time and the numbers really that we could provide people with really individually tailored support that was quite intensive at times. So we're really lucky in that sense. What did we achieve? I think one of our primary focuses was to establish the weekly clinic out of NTARC. And once we got this rolling, we then looked to take it to pop-up clinics and then we eventually took it out to the secondary NSP site. I think that coincided with the It's Your Right kind of timing campaign. So that was really successful as well. We also worked really hard to engage stakeholders locally and found, champions within the GP and pharmacy space, which was great. And we also engaged with AOG, corrections, AMSs, and any other organisations really that we could think of that would be working with our priority group. So we were able to engage and that gave us an opportunity to promote our clinic and our model of care and just the support that we were there to provide to both the service and the clients. We also work really closely with the NT Health viral hepatitis team. We've got a really great working relationship with those guys. We've got wonderful IFD doctors and a viral hep NP. And they will often refer people to us who they think might need some extra case management or support. They'll often give us their did not attends as well to try and follow up, which has been quite successful, I think. And then we in turn refer people back to them. So we pick their brains and their, use their clinical expertise, and then we refer clients back who are requiring that more kind of specialist care. So we've got a really great relationship with those guys. What else do we achieve? Shaking hands. In 18 months, we supported 159 people to access Hep C care outside of the hospital. And we had a positivity rate of 31%. And of that, we've thus far treated 61%. So I think we do have quite a high positivity rate, but we do have quite low numbers in general. So, and I say thus far because I think it really is an ongoing process, absolutely, because not everyone's ready at that time to start treatment. I know there's some people that will probably get there eventually. We're kind of just sitting beside them and waiting. And there's some I know that we probably will never get through treatment because of comorbidities and things like that. So we've treated everyone that we think we can treat for now. And we're really proud of the treatments that we've done, because I think they were predominantly with people that have had negative experiences with health services and been disengaged from health services for quite a long time. So I think we've worked really hard to get them engaged. So absolutely, incentives played a big part in our person-centered approach. And as time went on, I think we became a lot more flexible with that, and we have definitely learnt that that's the best way to be flexible. And it's a really great investment. So another outcome, I think, was that trusted relationships we've built with people now has allowed us to re-engage and link people back into care with other health services and to address other health and social issues outside of their Hep C. I think Sal and I are both really passionate about, like, each time we have any sort of engagement with people, we try to make it a really positive, non-judgmental interaction. And we feel like we're really just warming up. It's gone really quickly the last 18 months. I feel like now people in our community are just starting to hear more about us, talking about us, and it's really heartening. Then we're having people come back into the service who have been referred from their peers, who have said that they've been in and they've had a really great experience, and they're encouraging their peers to come in. So that's an absolute win for us. And then, of course, there's the Nurse Peer Partnership, and it's Sal. So it's been an absolute delight and privilege to work alongside Sal. And I think, yeah, her little quip about when I was hitting the books, she was out doing the prac, definitely sums up our working relationship. And it's like the nurse peer models are just brilliant. So we need to get onto those.
Just quickly, Angie and myself, sorry, we've engaged in the Nurse Peer Partnership. Angie and myself, has turned out to be quite a match made in heaven for our clients and ourselves in our work life. Our passion for our work, compatibility, and how we complement each other means we have all bases covered in the different kind of clients we come across. We left our egos at home with this one, and by that I mean if a client took to one of us or the other, we rolled with that. An example I can give for that is I'm big and bold and loud, and when there's a client come in with mental health issues, it was quite the opposite of me. And I could see that he took quite well to Angie, and we would comfortably let that happen. And I'll step aside out of respect to what would suit that client most. And I just feel a peer is able to be the ideal conduit in starting the relationship building between nurse and a client. You're able to give that comfort zone. And I'm being wrapped up. That's it. Thank you. Thanks. Oh, well, yeah. Okay. Oh, yeah. So many things we learned. But we wouldn't do differently because success. Oh, sorry.
You were just meant to talk to that. You didn't have to.
Oh, I know. Okay. Sorry. We felt we did it really well and wasn't much to perfect on. Is it really it? We just can't imagine how much better it'd be with another go at it because of how well-oiled a machine we are. And but we realized it was impossible to capture everything that we do. So to come up with some sort of data collection mode to cover all, like it's endless, the amount of stuff that we do, and we just never got across that with all the data. So thank you. Thanks.
I will say these guys also constantly reflected and changed, and I'm going to use the P word, pivoted, as they went. So I can understand that this is probably a bit tricky for you guys because you were constantly changing up until last week. So any questions for Angie and Sal? Erin.
I'm just wondering, I guess, if you have the funding to keep going, and was a lot of this dependent on EC, and so there's risk of it collapsing, or
Yes.
you've got something secured by like the health department?
No, so I think we've been funded by EC, which has been wonderful. And at the moment we're fortunate, we're starting Quick Start with Burnett. So we've got going to be using that funding, I guess, to keep our model of care rolling, and we'll just incorporate Quick Start into that. But after that, we'll be desperate and looking for money. So anyone want to give us some? And I think we're going to NT Health, I guess, with a business case to try and implement the model permanently, but I think how that goes.
Thank you both. That seems like a bit of a sad way to end. So you just find people and they'll just be desperate, and the government will see that. So the next group, thank you very much to Rachel and Jeanette from Hepatitis Queensland to talk about the Community Corrections Project.
Thank you, Jackie, and thank you, ECA Australia, for funding for our project. My name's Rachel and this is Jeanette, our community nurse, and we're from Hepatitis Queensland, and we're going to present today on our Hep C testing and treatment clinics at probation and parole, or community corrections, whatever you prefer. We know that people in correctional facilities have higher rates of hepatitis C than the general population. We also know that people reporting to community corrections are less likely to be engaged with healthcare than the general population. And there's also a higher representation of people who inject drugs in that cohort reporting to community corrections. So Hepatitis Queensland worked very hard to establish a monthly clinic at a pilot site, I guess, at Redlands in Brisbane. The wonderful work of Winnie, our colleague here today with us. A lot of groundwork forming those key partnerships, champions at the place. Memorandums of understanding, working out clinical governance, and there's a lot of work behind what you see at the other end that Winnie worked on tirelessly. So we started with our pilot project once a month, like I said, at Redlands. And the model had a GP, our community nurse Jeanette with a FibroScan, but also key to Jeanette's role is the ongoing support that she provides to anyone who's diagnosed as Hep C positive. It's absolutely critical with this cohort. Jeanette is checking in with them constantly. How are you going? Have you got any side effects? Have you picked up your script? Can I get it to you in some amazingly imaginative way that only Jeanette can come up with? So she's incredibly persistent and resilient, which I think is reflected in our great results. We also had full phlebotomy services at our original pilot site. We had a lot of problems with like everybody else, so we just kind of had to take a bit of a pause and regroup and keep working on the model, ready to relaunch. On the back of the successful model, we then transitioned into 2 new sites across Brisbane, which have also been very successful. We also then introduced point of care testing. Thank you very much to Quinn, hi Amanda, who very kindly lent us their machine for a number of months. We couldn't have done it without Quinn. And then we were very lucky to support a machine through the National Point of Care Testing Program. So yeah, I'll hand over to Jeanette to talk about our numbers.
So what we achieved in our time, so we had 10 to 36 clinics. We had 33 clients were scripted through the Hepatitis Queensland program. Community corrections clients screened, there was 183. And out of those, our data, 66% of these clients either reported a history of or present injecting drug use. 6 clients required to be referred to the specialists, and a couple were re-referred because they were just constant contact with them. 14 clients completed treatment, and mostly for the follow-up with phone calls, and they're not a 9 to 5 crowd, so there was a lot of evening chats. Use of a treatment fund for payment of their medications, which we discovered we needed. I ended up at pharmacies with them, lost wallets, no money, and I was digging into my bag. So we started the treatment fund, and we have the new addition of earrings dish at the moment, hot off the press. I need to rattle the tin. Anyone wishing to donate. A donation can be gifted the pair of earrings.
Come and see us.
Yeah.
Some here
It's
today.
we do hand out payments of treatments to other services, and I do treatments of payments from the clients I see within GP surgeries. So yeah, please. Okay, then 44 positive tested for HCV RNA. And, you know, sometimes I don't get to follow them up completely because of loss of contact, and reincarceration is a big roadblock for me. And then what we're learning.
Yeah, so our learnings for us is that we know that hepatitis C testing and treatment in probation and parole is definitely a big public health opportunity for the elimination of hepatitis C in Australia. And also that this clinic model can be very easily replicated. We're getting phone calls. I'm doing Zoom meetings all across Australia now where people are interested as to how we did it and what the key success factors are and so on. What we would do differently. What do I do there? Press on that. Yep, there we go. Yeah, we need to improve our SVR 12 rates. I think we're all struggling with that. We'd like to see if we could get some funding to incentivize that. And also we do have some issues with linkages to specialists. So we do come across some people who have some cirrhosis, and when we refer them to specialists, they're just not going. So we're going to maybe see how we can experiment with getting some transport for those people, and also maybe some peer workers in that. We're not sure yet. Thank you.
Thank you very much. So I've got Margaret, who I think just beat Colin by a whisker. But we'll come to you next, Colin.
Sorry, Colin. Really simple one. I'm not a believer necessarily in SVR12s. Do you feel you need to be, or do you feel like that you can just trust the client to say, I took most of the medication, I suspect I'll be right?
All of the people I did follow, I did get them to, I know they took their last pill, or I know when they took the full month of Mavorite or their second month of Epclusa. Those ones did pass, they are cured as well. But I did get an SVR for them. So all the ones that
I'm just wondering whether you reckon, do we reckon that can float off into the distance?
we could give it a miss.
Yeah, if you said to me that all the punters said I took the tablets,
Oh, yes, yes. See, some of mine that I did.
then I'm going to believe you and I'm going to believe them.
Yeah, I did
Just-
believe them.
Yeah. So what I'm saying is I don't reckon you need it. Save your dosh for something else.
you.
Colin.
G'day, I'm actually going to stand up. So I'm from the Institute for Open Indigenous Health. I actually left Quinn after starting that peer project. Out in your catchment area out there, I'll just recommend if they identify as Aboriginal or Torres Strait Islander, send them over to MobLink. They have care coordinators that will transport them to those specialist appointments and also pay for the medication. So you're welcome. But moving forward, I think, you know, like with Dorrit and nurse practitioner Mary Fennick and that, they do really deadly work. So sorry to ruin your limelight, Dorrit. But SBR4s were probably like something that you could probably do. But if they've already said that they've done the treatment before, they know that they finished that medication. And if they haven't skipped it, you know, like it's something that you just know. They can just do another point of care test and get it like a $20 gift voucher from Quinn, save it. The other thing is the community corrections setting is really deadly that you're doing that. So we have a really close relationship with the Greenslopes and the Brisbane Central Community Corrections. So when we are doing the treatments, normally obviously don't disclose that they're doing treatment through us for anything. But most of the time, it's one of those places where it'd be good if you were there, because I do take them out to Dorrit and Yep. A lot of the time, though, is they don't normally finish the treatment because they're returned to custody. So if they could actually then follow up with Dorrit straight away. So if you could just do a partnership thing, that'll be deadly and save my job.
Yeah. When I do find my clients have gone back to, have been reincarcerated, I tend to get in contact with Chris Wallace, Lynn and Joe, and find out what's happened to them.
Excellent. This is problem solving in real life right here. Thank you very much. Yeah. And Rachel. And now, because they're all talking about you, Dorrit, you may as well come up and have a chat about the prison transition project at Quinn. Thank you.
Thank you. First, I'd like to acknowledge the traditional owners of the land on which we meet on today, and I'd like to pay my respect to the elders past, present, and emerging. So I am the prison transition worker for Quinn, and I've actually done this work since February 2019. So my work includes linking people between prison and community services for upstart or ongoing Hep C treatment or support. In 2020, we got 12 months funding from ECA Australia. So from the start until end of 2021, I had 600 people referred into my services from 13 different prisons in Queensland. Although I personally only go into 4 prisons on a regular basis. To update that number, I reached 880 cases today. So when I see clients mainly in prison, I sort of screen them and I identified that about 67 2/3 have actually had a blood test. That could be either in prison or in the community before they get into the prison, and that need to be followed up. So it could be either just getting the results, or if they had results, they start to get scripted, or if they are scripted, then support them on treatment, or if they need an SVR results. So the follow-up and referrals which I do is either in the prisons or in the community. So in prisons, it's quite easy because we know where they are, unless they get released before following up happens or the referral happens. And that has actually led to, you know, quite a few get released before they have commenced treatment. So the medication is sitting there and they get out. So I have personally delivered 27 treatments to clients in the community after release. So in the community, there's quite a bit of a different situation. So even though the clients have been provided with my client card on release, they don't always call me. And that is where my detective skills sort of start kicking in. So over the years, I have tried to expand and see as many clients as possible in prison, so that feel more comfortable to, you know, contact me on release. And I have engaged with each prison that I go into regularly, sort of to find out what is the best way to engage with this particular prison. So in some prisons, I physically attend the induction. So I am there once a week when the new receptions get inducted, and then I hand them out a referral form or a request form that they can see me. And then after that, I will meet them one-on-one and find out where they're up to. I have also done some education section. And because I'm in there on a regular basis, I have built very strong relationship with stakeholders and clients. So what would I do differently? Since the program has, or since I've been working nearly up to 4 years now, I have had time to reflect as well on my role. In the beginning, I did not have a dedicated car, and I travel a lot. I mean, I drive a lot. So that was a bit of a, sometimes a issue that I didn't have a car. Also, I do a lot of paperwork. In prisons, I'm not allowed to bring in a laptop, which could save me a huge amount of time, because I need to get people sign the consent forms. I have to, you know, get them uploaded when I get home. And I also want to say, be prepared for change of plans, because nothing goes to plan when you go to prison. Always have a plan B, just in case plan A doesn't go ahead. And, you know, the variation of clients have also, because of COVID, and then you have the build up, and you have to be aware of that it can lead to burnout, because it's a lot of cases sometimes and a lot of stories to take on. So you have to know your limits. It's a very lonely job because it's only me. So I would love to get more hours and more staff available. And I think that with the talk that I would like to have better connection with community corrections, probation and parole, because that is a place where I often go to find my clients once they get out. And I want to end up with saying that more training could be useful in prisons for both staff, correctional service, and also prison staff. They still come up to me and ask for questions about Hep C treatment. And that's it.
Any questions for Dorrit?
Oh, it's not really a question, just a statement. But I just want to say that since Dorrit's been with us and over the 4 years in the build up, like we've definitely noticed the difference. If a client gets taken into custody, I email Dorrit and say, oh, mate's in custody. She literally gets back to me within a few hours after contact the prison, and we've got the person results. We've got follow up. They know they're on treatment. They've got their script within a couple of days. We still have a bit of a battle with the watch house, but that's pretty standard. But Dorrit is amazing at getting into the watch house too. So if we could replicate Dorrit across Australia, that would be awesome. And also a Dorrit for OST transition to make sure that happens as well. That'd be good.
Thank you. And the last speaker of the session is Megan Hughes, talking about the Tasmanian Eliminate Hepatitis C Australia outreach program.
So small. Okay, hi everybody. I'm Megan Hughes. I'm the clinical nurse consultant on the Tasmanian Eliminate Hepatitis C Australian outreach project. So I'm going to talk a little bit about this project. We kicked off in May 2020, and we're based at Sexual Health Services. So thanks to Louise Owen for taking on this project and taking on me to be out there and testing and treating people for Hep C was always our aim. So to get out there into the community, into priority populations and increase Hep C opportunities for Hep C screening and hepatitis C treatment. So before this project started, a lot of our hepatitis C care was tertiary based. And, you know, for a lot of our clients, that wasn't a suitable model of care or one that they wanted to engage in. So started out with, you know, engaging our priority populations, which was mental health services, alcohol and drug services, and NSP services and correctional services. And throughout the last 2 years, I've been doing regular clinics in 6 NSPs across the state. So that's a drop-in model clinic for venipuncture testing for hepatitis C, all bloodborne viruses, and it's reflexively tested so that they only need bloods once, and then if they are positive, we can start treatment off that. So that's been a major success of this project, and I'd just like to thank the NSPs. They promote these clinics, they promote that people can come and talk to me, and that's been really, really successful. So I've tested about 300, I cannot read the numbers, it's so small. I've tested about 370 people in the NSP sector. And then overall in the project, I've tested about 450-ish people. In AOD and mental health services, it was a little bit different what we set up. So what we set up there was that testing became a routine test on admission to service and then annually, so that when someone was admitted to a mental health facility or if they were on OAT, their annual blood review would include hepatitis C testing. So it was a different model. It was about them just routinely doing the testing and then referring to me when they identified a positive patient, and then me working with that person to start treatment. So that was different to the NSP, where there was no clinical services. So we kind of just came in and provided a clinical service. So I think that this project's been really successful. There's also been an element of education. So I've done a lot of education in AOD mental health services. I think in mental health services specifically, I've provided training to over 200 staff on hepatitis C. So on to numbers. I can just look this way. So we've had 80 people who are Hep C RNA positive come into our project, and 74 of those people have commenced treatment. So we're sitting at 92%. which I will say, I think we were going to get higher by the end of the year. Thank you, Anna. We'll get higher by the end of the year because, you know, some people won't start straight away. This is a journey for people. Just because we want this to happen right now, doesn't mean that someone has to start treatment straight away. So I think that's an important point to remember when we're doing, you know, looking at, 12 weeks, did they start? Did they stop? You know, for some of these clients, it's taken me a very long time to help them access treatment, but when they're ready, we get cracking. SVR rates are probably sitting around 50%. So again, it's a bit harder to get people back, but I hope they feel better and they don't feel that they need to come and get that confirmation. In terms of outreach clinics, I've been out and about a lot. I've done 272 clinics over the last 2 years in predominantly NSP, but also AOD and mental health settings. Just for some context, about 40% of the people who have been positive have come from the NSP setting, and then it's 20% mental health, 20% AOD, and whatever's left over is other. And I guess an important point is about a quarter of the people I've seen who I've treated have been on antipsychotic or antidepressant medications, and about a quarter have also been on OIT. So it's really disappointing that they weren't treated elsewhere because they were in care. What would have been done differently? I really like Angie's statement that you do learn as you go. So maybe if I'd done things differently, we would have missed things. But definitely a good thing would have been having one nurse in the south of the state and one in the north, because we have done a statewide project and there's been a lot of travel. So to have one of us south, one of us north would have been great to reduce travel time and cost. I think we set up a steering committee that wasn't particularly helpful. I think a less formal engagement from our key stakeholders would have been better. And I'm out of time, so just read the rest. You told me so many times.
Any questions for Megan? Elisa and Clancy? Hello, Clancy, the microphone's coming. There was a last minute change for Anna, so she's good on you.
Well done. You've got some really great figures. Basically what I'm doing is very, very similar to you, except I have access to the gene expert, which is amazing. Did you find that you lost many that you couldn't get bloods on, being, in NSPs, being clients obviously that have difficult venous access?
I think 3 people perhaps. So yeah,
she goes for the shin. She read me one day and she said, I've just taken blood from somebody's shin. But I'm so not that kind of nurse.
With consent, I will say.
Right.
Yeah, so I've just got a gene expert, and it hasn't changed the world, and it hasn't been amazingly different for my service. So and interestingly, a lot of clients still opt to have venipuncture because they'd like to know what their liver health is like. They'd like to know if they should go have Hep B vaccinations. So we've just introduced that. I didn't include that in my numbers of people tested because that's been just the last couple of months, and it hasn't been a game changer for me. So yeah, but also I think venipuncture is a discussion with a client, and if someone is injecting drugs, they will probably be able to tell you where a vein is. Yeah.
There's probably a question for you, Megan, and then also for Dorrit. I forgot it earlier, but you might be seeing clientele that may be getting reinfected, and we are seeing retreatment numbers go up nationally. Are you, what's your experience like with people coming back for re-treatment? What's their attitude? Are you kind of finding that a bit more difficult, or is that quite?
So yeah, there's been lots of different experiences of that. So a lot of self-stigma and self-shame, and I think people have sat on those infections for a while longer. Still some misinformation that perhaps they're not allowed to come in, but I would say more than not allowed, it's maybe I'm too embarrassed to, or maybe I shouldn't deserve this. So, we talk about a lot, that this is the best thing for them to do. And I do notice that they were a bit more hesitant. So say they got treated by their GP the first time, there's no way they're going to the GP the second time. So that's kind of a theme I've seen. And I've just looked at how many people, what treatment number it was for clients. And I think off the top of my head, maybe about 50% of people were second or more treatment, and I've just seen someone for their 5th treatment. And overwhelmingly, the I guess risk factor is incarceration, where you're seeing those infections again and again and again. But we all know that. I guess, yeah, I think it's, we just got to support people and let them know that, we want them to come in for treatment regardless of that. But yeah.
I just want to agree with you that in prison, the number of reinfection is getting very high. And that's one thing that I do encourage specific with the inductions when I talk to them, that, we will retreat as many times as it's necessary. And that seems to get across now, and that makes them come forward to do another test. And yeah, as you said, I've seen someone, it's the 5th treatment they're on now. So it's going to go higher up the reinfection rate. And that's why I think they're very keen on do the SVR4s now, just to make sure it's reinfection and not a treatment failure.
Stop is the sign that is in front of me. Thank you so much to my speakers in models of care, but also workforce development and client engagement. Thank you very much. It's been a great ride, and I'm truly grateful for all the work that you've done. I'm now going to hand over to Professor Stu.